Hi, everyone. Welcome to another installment of the Dutch webinar series. I'm Dr. Kelly Roof, a clinical educator here at Precision Analytical, creators of the Dutch test. In today's webinar, we're excited to welcome Dr. Doug Lucas, who will be exploring the world of bone loss, hormones, and Healthspan. We've had him on our Dutch podcast before, but it's his first time now doing a Dutch webinar with us, so we're really excited to have him here. We hope you gain valuable insights into a more effective and integrative approach on this topic of bone health. And so thank you for joining us. Dr. Doug Lucas is a double board certified physician specializing in osteoporosis reversal, hormone replacement, and health span. After completing his training at Stanford University and practicing for nearly a decade in the field of orthopedic surgery, he left his practice to pursue an additional fellowship and board certification in anti-aging and regenerative medicine. He went on to achieve the status of fellow in anti-aging and metabolic medicine. This functional and hormone training gave him the breadth and depth of knowledge to support his deeply held philosophy of patient care and to start Optimal Human Health MD, which is his nationwide telehealth practice. The OHH team now focuses exclusively on bone health through the lens of optimization, with a dual mission to educate the world that osteoporosis is reversible and provide an unparalleled patient experience. If you're ready to start using Dutch testing in your practice, sign up, become a registered provider today. It's really easy. Just click that link that we posted in the chat and complete our provider application form. A member of our onboarding team will walk you through the steps to set up an account so you can begin taking advantage of all the education and resources that Dutch has to offer. Plus, registered providers gain access to our entire educational library, including courses like perimenopause management, introduction to HRT, and mastering functional hormone testing. We also have the Dutch interpretive guide, and we just came out with the Dutch treatment guide. And we offer one-on-one consultations with our Dutch clinical educators. This dedicated support and education is, of course, designed to help you become the hormone expert. We're also excited to announce an update coming this fall, enhancements to the Dutch report. The updated Dutch report, launching October 15th of this year, will contain a simplified summary page for faster interpretation and better patient outcomes, including a new interpretation framework that will help you understand the Dutch test more intuitively. Stay tuned for more information in the coming weeks. And we have a disclaimer. Please note the contents of this webinar are for educational and informational purposes only. The information is not to be interpreted as or mistaken for clinical advice. Please consult a medical professional or healthcare provider for medical advice, diagnosis, and treatment. And of course, if you have any questions as we go, please submit them. And we'll do our best to answer and address them in the chat and in a follow-up in the days ahead. So be sure to follow us across all social platforms to stay up to date. It's really a pleasure to have you with us today, Dr. Doug. Take it away.
Awesome. Well, thank you, Dr. Kelly. Appreciate the opportunity to talk about this topic, particularly bone health and how it relates to drug urine testing and how we've really kind of incorporated this into my practice. The big picture here for me is that I've been in a bone health space for a while, and I'll give a little bit more about our practice. But the big thing for me is that I've really identified that bone health in my practice is something that we need to have a completely different perspective on. It's something that I think is really misinterpreted as a diagnosis of the elderly, meaning osteoporosis, but there's so much more we can learn from our bones. We're going to talk about all of these things throughout the course of this. A little bit more in depth into my practice so you can understand where I'm coming from. So Dr. Kelly gave my intro, all that's true. But the practice called Optimal Human Health was recently acquired by the company LifeMD, with the idea that we're going to build a bone health program on a scalable platform. And this is a really fun challenge to bring, kind of bridging the gap between functional, integrative, conventional, telehealth, and all at scale. So super excited to do that. But what that really says to me is that what they saw and what we had built is the opportunity to, again, treat bone health a different way, look at bone health a different way. We also have this fun community called the Osteo Collective where we continue to build resources because there's just so much when you get into the bone health space. it encompasses everything from nutrition to exercise to hormones to supplements. Like, it's got it all. So it's a really fun place to be. So from a numbers perspective, they really tell a kind of bad picture around bone health, and they're actually not even the whole picture. But what we have listed on here are some of the commonly cited statistics around bone health. So if you have a hip fracture, 20 to 30% of people will be dead within 12 months, right? The mortality rate is higher than most cancers. That's not even the worst part, because actually about 30%, or sometimes up to 60%, depending on what you read, up to 60% of people with a hip fracture will lose their form of independence. How independent they were prior to the fracture, they do not get back to that after. And that's the part that I saw more as an orthopedic surgeon, was really that change in lifestyle. It is truly a life-changing event. Either it kills you or it changes the way that you live. And it's interesting that when we look at, as I have listed here, the top 10 causes of death in the US, if you look at these top 10 causes, accidents is listed there at number 4. Now, if you go back pre-pandemic, it was actually number 3 before COVID snuck in there. But accidents is listed either at number 3 or number 4 consistently. And if you look at how that breaks down as we age, you can see that fractures and falls are the number 3 cause of death over the age of 65. So heart disease, cancer, and then falls and fractures. And you might argue, well, look, but this is just in the elderly, right? These are people in their 70s and 80s, and this is just part of aging. But ultimately, if you want to prevent these fractures, you actually need to start this much earlier. And this is where having conversations around hormones and lifestyle and what things can we do that are going to actually have a positive impact on our bones and prevent these falls and fractures in the future. I think one of the biggest challenges in the conventional medical model is, again, that we are trained, as an orthopedic surgeon, I was trained that osteoporosis is a disease of the elderly. There's not much we can do about it. It's just part of aging. And if you get diagnosed early, you can consider a pharmacologic therapy, a bone drug that's going to do something to your bone metabolism. But ultimately, this is just a part of aging. And I can tell you in our practice that that's not what we see. Because in our clinical practice, we have people in their 50s, 60s, 70s, 80s, and beyond that are slowing down bone loss, plateauing out their bone loss, and even improving bone, actually in the majority of them, if they have the ability to do the things that we know are good for bone. So I've started looking at this a different way. So instead of looking at osteoporosis as a disease of the elderly, I look at osteoporosis not as a T-score, but as an imbalance in bone metabolism, right? We're always breaking down and building up bone. We replace our skeleton about every 10 years. So if that's true, then osteoporosis is simply just too much breakdown, not enough buildup. So then all we need to do to reverse it is to flip that equation, go the other way, more building, less breakdown. Sounds simple. It's not necessarily easy, but it sounds simple. But if you look at osteoporosis that way, then it changes the way that we look at improving our bone health. I think this is really important as we look at health span and longevity, because bone health is really connected to more things than most people think, right? It's strongly connected to hormones, actually communicating back and forth. Mitochondrial health has an impact on bone and vice versa. Inflammation will have an impact. Oxidative stress, sarcopenia, muscle loss, metabolic dysfunction, all of these things interact and have communication with and impact bone, and bone will interact with these things too. It really is more communication happening in the body than most people know. So again, ultimately, instead of thinking about osteoporosis as a geriatric disease, I want us to start thinking about bone health as a biomarker of health span. If you're losing bone, something's wrong. If in my practice, people in their 50s, 60s, 70s, and 80s are plateauing and improving their bone density and quality and reducing their fracture risk, we do not have to accept that bone loss is a part of aging. I think when you look at the traditional decline of bone density on average in the population, what that's really mirroring is the health of our population. Health is declining. So if you're losing bone, something's wrong. Bone health should be considered a biomarker of health span. So let's talk a little bit about what we're seeing in the community. So for people that come into our Osteo Collective or people that came into our clinical practice, we're looking for things that can help us to understand why you're losing bone. It's not just about the T-score. So when people talk about some of these symptoms here, you can see these are all about, or potentially could be about, hormone fluctuations, whether it be male or female. One of the things we see obviously around menopause is this reduction in estrogen, reduction in androgens, testosterone, DHEA, we see consistently in our osteoporosis population cortisol dysregulation, whether it be high or low. We see irregular cycles on our women that are still cycling. We see these things over and over and over again. And yet we know each of these hormones, estradiol, testosterone, progesterone, even DHEA, all three of these primary sex hormones are going to have a tremendous impact on bone remodeling, on bone building, on bone breakdown, on bone metabolism. So it makes sense then, so if we can leverage our sex hormones, which we're already talking about, if we can leverage these things in a way that is good for our health span, our longevity, and our bones, we should probably consider that. We know that if you are, again, losing bone, bad things happen. Bone density is actually a predictor of survival. For every standard deviation, so that's a T-score from like -1 to -2, for every standard deviation drop, your mortality almost doubles. So this is really a big deal. Now, going back to the longevity piece, I would love, of course, in our 30s, most people in our 30s are not really thinking longevity, but as we start pushing this type of conversation, this type of health optimization, this type of integrative functional mindset into a younger population, I really think it's important that we start understanding and screening what's happening with bones earlier in adult life. Because again, we reach our peak bone density at around 30, and then it's a gradual decline. That gradual decline doesn't have to happen. If you're losing bone, something's wrong. Here's that graph I talked about. Again, you see this peak bone mass right there where the red and the blue line peak out, and then it starts to drop. And you see that, of course, that little S curve around menopause for women. That curve does not have to be there. So let me get into a little bit of the individual hormones here. So testosterone, which is an interesting one, especially because generally we're in osteoporosis, we're talking more about women. But testosterone is important for both women and men because it has the same impact on the cells regardless of sex. So testosterone stimulates osteoblast activity. Those are the cells that build the bone. And if we're going to do both sides, you need really the side that builds generally is the one we have to work on more. Testosterone also, of course, will have an impact on muscle mass. We know that testosterone in studies will improve bone mineral density. We think it will reduce fracture risk. There was a study from just this year recently published showing testosterone use in postmenopausal women reduces fracture risk. But we don't have great data in women. We have more data in men than we do in women. And even then, the studies aren't big enough and they're not done for long enough. But ultimately, it makes sense. This is physiologic common sense that having adequate androgens will support muscle, will support bone. And if we get into cortisol, again, you can see this either high or low. And this is where I think there's a lot of value in using a test like Dutch, a dried urine test, where we can understand, I guess it would be a saliva test, but using these types of tests where we can get a better sense of what's happening with some of these hormones than we can in serum. Most of our testing is in serum. I'll talk a little bit more about that later. Most of our testing is in serum, and we use these to really truly optimize and dial things in. Because I can tell you, we get fasted morning labs, we get serum cortisol, and I can tell you that that lab is, I don't want to say it's worthless, but there's not a lot of clinical value that I can get out of it because there's so many variables. Did this person, as they were going into the lab, were they in a traffic jam? Did they get cut off? Did they walk in and they're scared of needles? Did they almost pass out? All of these things that can cause a spike in cortisol, right? Because what we really want to know is what's happening before you wake up, as you wake up, and what happens throughout the day. This is where diurnal cortisol is so valuable. And we know that from a bone health perspective, if you have chronically high levels of cortisol, it's going to break down bone. Just think about the extreme, which is being on like prednisone or a steroid. We know that rapidly breaks down bone. It's true for endogenous cortisol too. And then we also know that the opposite is true, right? So if you have the inability to make cortisol, call it whatever you want, but if you have the inability to make cortisol at adequate levels, we know that also will have a negative impact on bone, maybe because of the association of oxidative stress, inflammation that usually comes with. But both states out of what we are looking for from an optimal perspective are going to have a negative impact on bone. So what we see is sort of like the perfect storm is when all of these things kind of happen all at once. And again, we see this universally in our community and in our patients. We see women either in perimenopause or menopause or even earlier in adult life with low levels of estrogen, so they're losing bone more quickly. They have low levels of androgens, likely because of stress, because of some kind of systemic dysfunction, dysregulation. Their ability to produce androgens is dropped as well. They have high cortisol because they're fighting something. something's going on that's provoking this elevated cortisol. And then if you put all of these pieces together, it can result in rapid loss of bone. So from a clinical perspective, understanding what's happening with hormones is important. And I can tell you after, I don't know how many thousands of blood tests I've done, after looking at thousands and thousands of blood tests on hormones, I can understand why there are some doctors who say we shouldn't even test hormones because the tests are all over the place. And it's true. They are all over the place. I still think there's clinically meaningful information to be gathered from serum testing, but I do think that there's value in adding other forms of testing to help to see a clearer picture. And this is why identifying imbalances early, especially, for perimenopause and for premenopausal women, what's happening, if they're having symptoms, if they're losing bone, what's going on. Looking at more extensive tests like cycle mapping can be really helpful to understand what's happening. Is a woman ovulating? What's happening with her progesterone levels as she goes through the luteal phase? All of these things can have a serious impact on bone and provide you with targets in which to treat. All right, so let's get into some of the deeper insights here. So again, bone loss is not the disease. Bone loss is a symptom. I think there's supposed to be a little equals with a slash through it right there. We know that hormonal dysregulation will result in bone loss, both in women and in men. And if we can find it early by screening, by asking about symptoms of hormone dysfunction, by doing this testing, we can see that we now have tools from an intervention perspective. Again, this just sort of repeats the idea that through life, we lose bone as we lose hormones. These things all mirror each other. We know that these things are so tightly controlled and tightly regulated. But when it comes to optimizing hormones, most physicians, providers, people, in the hormone space, especially if they're new to the hormone space, get really overwhelmed. You look at a chart like this and you're like, like this is so complex. How could I possibly figure out how to treat somebody with this type of information? But the right testing will help to clarify what the problem is, the thing that you can actually treat, and it can hopefully send you down the right pathway. So then let's talk about a couple of clinical scenarios that can help us to identify the pattern of what we're looking for. When somebody has bone loss, like I said early on, osteoporosis is generally not going to be, from the way I look at it, not just a T-score, a disease of the elderly. It's also not just a calcium deficiency, as it seems like most people think. It is sometimes a vitamin D deficiency, or at least it's vitamin D related. But a lot of times, one of the first clues of some kind of an endocrine imbalance actually can be bone loss. So this is, again, why I say over and over again, bone loss is a biomarker of Healthspan. If you're losing bone, something's wrong. If you see someone losing bone, one of the first things I would look at, maybe after nutrition, maybe after sedentary lifestyle, would be hormone imbalance. Those three things have to be evaluated when someone is losing bone, especially if they're young, especially young women. So let's talk about some of these patterns that we see clinically. If you look at this graph, this is a graph of, the lifespan of a woman. You have childhood, reproductive, perimenopause, menopause. This is estrogen and progesterone. Of course, this is, cartoonish. It's not actually what it does, but it gives you the idea, right? So that time in perimenopause, and especially as you get into menopause, you can see that estrogen it's up, it's down, it's all over the place. The symptoms that come from that are very real, and oftentimes they can be treated. But what we'll see with this is bone loss, because as estrogen drops, we lose, well, it's not true. As estrogen drops, our breakdown of bone actually increases. As progesterone drops, we lose the drive to build bone. That natural push-pull of estrogen and progesterone throughout the menstrual cycle is a powerful stimulus for maintaining and developing bone. If you lose progesterone, even as a premenopausal woman, if you're not ovulating, if you don't have at least 5 normal cycles, you're still losing bone. So we know that we need both. So clearly, as women go through perimenopause, as they go through menopause, we have to have the question around, do we replace these or not? And of course, not everybody is a candidate, but we need to have the conversation and see what's happening. This is just looking at like what's happening with progesterone dysfunction. Again, we want to identify, is somebody, these are going to be like cycle maps. So does a woman have a rise like you'd expect to see in the luteal phase? Like this one, for example, probably a shorter cycle, but you can see she has a rise. It's within the normal range. It's normal-ish. I'd want to know more about the durations. It's pretty short, but this is at least some progesterone. So then let's talk about androgens again. So from an androgen perspective, we want to look at the testosterone. We want to look at the breakdown. We want to look at what's happening with DHEA too, because not all women tolerate testosterone. Not all women want to be on testosterone. So it might be too that we have the opportunity to potentially leverage other androgens like DHEA. We know that in women, these levels will decline. In men, these levels will decline over time. So the question is, at what point do we need to catch this and support it? And then if we're going to, which direction do we actually go? So then when we start getting into, why do we use a test like Dutch? It is to look for these variations when serum may look okay. And I've seen this where serum labs look okay, but they're still symptomatic. They're still losing bone. And the question is, well, what's happening? And a lot of times it has to do with, from my perspective, the biggest piece is what's happening with the metabolism of estrogen, what's happening with the detox of estrogen. And then, of course, the androgens and the cortisol in there too. But I think we're going to get into the detox of the detox of estrogen right here. So when it comes to optimizing hormones, especially optimizing HRT for postmenopausal women and perimenopausal women on estrogen, we want to ask about symptoms. And it would be so great if all women responded the same and we said, look, this is the dose you need for your bones and we're set. But that's not how it works. There are some cases where we will put women on the dose that we think, and their symptoms of menopause, if they have them, go away and their bones look better, and that's awesome. But that's not most of our patients. So generally, we see some, like either they have a hard time getting levels high enough, they still lose bone, or as we drive levels up, they're symptomatic of something, and we can't get to the level that we're looking for from a bone health perspective to optimize the biomarkers and then prevent the bone loss. And one of the key things that we'll do is to use a Dutch test. We will look at the urine metabolites, the the estrone detox, and then see what's happening in that pathway, because that can really help us to figure things out. From a cortisol perspective, I kind of covered all of this already. You guys probably know how to ask about the questions of, are you experiencing high cortisol or a flattened curve? Probably don't need to go into that here. Just a couple of treatment things. This is always variable. And again, people are going to tolerate it differently from one person to another. These are just some of our favorites. So for our patients that have high levels of cortisol, I've found a lot of value in the adaptogens. We also have in our practice, we have group coaching in our community. We have group coaching and one-on-one coaching available. And I think that's really important from a mindset and stress management perspective. But at least the adaptogens that I have listed here, ashwagandha, rhodiola, L-theanine, these things really do have an impact for a lot of, especially, really high cortisol wired women. The low cortisol piece, I think, is much harder. This is usually long-standing dysfunction. So some of the stimulants, if they can tolerate it, like licorice, there's really not another one that I would put in there that is, I think, tolerated well. Really working on circadian rhythm and optimizing metabolic function. So the lifestyle piece here is probably the most important, but there are some supplements that we do recommend. All right, so then let's get back to this estrogen detox. So we want to shuttle women down metabolizing estrone into 2-hydroxy. There's always going to be some level of 4-hydroxy and 16-hydroxy, but we want to shuttle women into 2-hydroxy so that we can detox that estradiol. I keep saying that, sorry, that we can detox the estrone, we can get the estrogen out of the system. If it's getting backed up, we have to ask ourselves why and what can we do about it? So ultimately, understanding what's happening from a detox perspective helps us to target and guide the dosing, so we can kind of slow down on optimizing the dosing, and we can work on the detox, and we can look at, where is the actual dysfunction. So when we see, signs of kind of a metabolic overload, we do see these high levels of 4-hydroxy and 16-hydroxy. And you can see this, as it comes through in the report. This can be a result of inflammation, oxidative stress. Again, all of this just load on the body. So our strategy then is using whatever antioxidant makes sense. It's going to depend on the individual person. Here's some of our favorites. But ultimately, we want to really reduce toxin load. We find value in kind of pursuing and looking at iron levels, copper levels, zinc levels, trying to balance out the antioxidant pathways. And then looking at methylation issues. Again, this is going to be, looking at the phase 1, the phase 2 detox pathways, and then supporting those. So for example, if somebody has methylation issues, using these potential options. supporting methylation through the appropriate methyl donors, again, likely driven by other testing as well, and then supporting phase 3 detox with calcium D-glucarate, et cetera. So we would just want to support everything going down this 2-hydroxy pathway. Once we do that, then we can help to actually optimize hormone levels without shunting estrone into these other metabolites like 4 and 16 hydroxy, which have the potential risks associated with it. So the reason why we do this, though, from a bone health perspective, is that we see the numbers around the research. And while in the US, estradiol is FDA approved for prevention of osteoporosis, the truth is, if you look at the research, there's tremendous impact on women that already have osteoporosis. And while we can't say that we use HRT for treatment of osteoporosis, what we can say is that for patients that have osteoporosis, we know that HRT being used for whatever indication you want to call it is going to have a tremendous impact on the bone. And you can see these numbers here. So that first citation is a meta-analysis. I want to say there's 12 or 14 studies in there, all on topical transdermal estradiol and some rhythm. And on average, if you average all those studies, the increase in bone mineral density over 12 months was 3 to 4%, which is pretty good. This oral estrogen citation is actually from the WHI. That was the 2002 study showing the 41% fracture risk reduction, even with conjugated equine estrogen, which I'm not a big fan of. Progesterone and testosterone, again, not as well studied in the bone health space. They're not studied independently. Definitely progesterone. Testosterone, there's a few studies, but not that many. All right, so then let's do just kind of a quick case study. So this is a patient of ours. She is now, so we have data going back, 2022. So this is 3 years of follow-up data. So she started when she was 51. And you can see, I think you can see my cursor, but you can see if you follow over from row 4, her spine in 2022 at age 51, her T-score was -3. Now, if you go down and look, just look at her total hip left, you can see in row 8 that her T-score was -1.5. Now, if you look at her hips over the course of the next year, her hip went up by 6%, which is great. Now, what did she do? Well, she did our program. We talk a lot about lifestyle. We have our foundational pillars. So she really worked on her sleep. She worked on eating the right foods, getting adequate protein, eating an anti-inflammatory diet, right? She worked on her mindset. She worked on her sleep, all those lifestyle pillars, working with our coaches. And then we optimize hormones. Now she is still, but she was a 51-year-old having gone through menopause and was scared to use hormones. Never used a drug in her life, didn't like the idea of drugs, wanted to do it naturally, and then at 51 was diagnosed with osteoporosis. So we had a tough conversation, and I said, look, you of course can do this naturally. You can go through menopause and not use hormones, but there is a predictable decline that will occur, and your starting point is not that great. So she agreed to start using hormones, and you can see within this first year that she did see improvement in her hip. Now in her spine, you can actually see in row 3 there, it went from -3 to -3.2. It got worse. And the reason why I love showing this case is because from an exercise perspective, she had all the other pieces in place. But while she was loading her hips, especially doing, leg press type exercises, she wasn't loading her spine. And she wasn't loading her spine because she had a little back pain, she has a little arthritis, and so she wasn't able to do the things that we recommend that are going to be able to pull load through that spine. And then as a result of that, she had all the, the milieu of hormones and food and all this stuff that she had in place. Her spine could have grown bone, but it didn't because it wasn't being loaded. There was no impetus. So then we had to work with our exercise physiologist and kind of came up with a way to load her spine without causing her pain. And then you can see what happened, right? So you go from row 3 to row 2, T-score -3.2 to -2.1, and that was an 18.7% change. It's pretty massive, right? And so you can see year after year, she continues to improve. Her hips continue to improve. She technically does not have osteoporosis anymore. She's 54 and she's very happy, one of my biggest fans. But she was one of our early patients, and this is why we have such long data for her. Here's another patient. This one is a little bit older. And this is a patient who, she's in her 60s. And this is a great conversation around, is it too late to start HRT? So I don't need to get into all the details of that here, but we did start her over 10 years out from menopause on hormones, but she had a lot of side effects. And this really bothered her because she was scared to start them in the first place. And she said, oh, but maybe this isn't for me. But we were able to use the right testing to be able to identify for her what is going to be a pathway forward and continue to use hormones. So when we do the right testing, we can start to get a sense of what's actually happening and where we can support her. So from her perspective, the biggest thing I see here is that, she still has quite a bit of cortisol overload. She has a really high peak and then a high curve throughout the day. So while her hormones, there's value here, and we're going to continue to talk about this. Really, for her, the biggest thing here is probably sleep. It's probably stress mitigation, right? So it can kind of take some of the perspective off of, am I on the right dose of hormones? What's happening with my hormones? And be like, oh, actually we have objective data that we really need to be focusing on something else. And then we look at the detox and we see, oh gosh, well, as you break this down, we probably need to continue to focus on your detox so you can get your levels optimized so that we can see your bone loss start to slow down, right? And so we can support her in the way that we've already talked about. Similarly, with the androgens, her androgen levels were very low. So this is a reason to find, do we have some kind of androgen that we can use, whether this be DHEA, whether this be testosterone. We already talked about this. So we know that if you have elevated cortisol, it is going to suppress osteoblast activity. Again, this is part of taking steroids or any kind of IV or oral steroid. So then we can match the findings with what we would expect to see with the things we already talked about. Having low estrogen progesterone, we're going to lose bone. If you have low androgens, you're not going to be able to build muscle. You're going to have a hard time building bone. If you have elevated cortisol, again, you're going to have suppressed osteoblastic activity. You're not going to be able to build bone. If you have detox imbalance, oxidative stress, inflammation, you're going to have an increased inflammatory load, which is going to cause you to lose bone. So then when we build these programs, again, we want to start with the foundation. This is, you can see this triangle here on the bottom. This is our framework for building programs. And I think probably every functional integrated practice has something that looks like this. But for us, these are the pieces that we break it up into: nutrition, exercise, sleep, and mindset. You've heard me say it already. We have to start there and then build on top the hormone optimization. There's so much controversy in the hormone space that, we really have to be confident in what we're doing and confident in our protocols and our approach, because we're going to get criticized, especially if we're talking about it openly, like I am, of how we treat patients and how we're doing it. And so for me, I know that I want to optimize the hormones, and I can use bone health to help me do that. Whereas just getting blood tests to get blood tests to look at numbers, I can see that there should be some criticism there, or maybe there should be some criticism there. But ultimately what I'm doing is optimizing the hormones. And then if they stop losing bone, because they're doing all the other stuff too, if the bone loss slows and then starts to go the other direction, I know we're probably in the sweet spot. So for this particular case, I didn't talk about the numbers before, but you can see that she has what is considered to be the sweet spot for estradiol for bone health. But I can tell you that this is variable from person to person, but most doctors in the space are saying 60 to 80 picogram per ml if you're in the US. Her DHEA is okay with being supplemented. That's a reasonable place for her to be, as long as her bone turnover markers are slowing down and bone turnover markers are looking like they're headed in the right direction, and her imaging does as well. So we don't really know the answer to this for probably 6 to 12 months. This is the framework we use for creating a bone health journey. So we call it the 4R method. And the reason why we created this is that I wanted a simple framework that anybody can do. Because while we have, several hundred patients, our goal is to have several thousand patients. This is a multi-million person problem, a hundreds of millions of person problem. So we really need to teach people how to do this on their own. So the framework is simple. Recognize why you're losing bone. And that could be through blood work, that could be through genetics, that could be through functional testing. It could be through, if you have the symptoms, using dry urine, and you can get a sense of what's happening with your hormone metabolism. Once you have an idea of what the potential levers are, then you build a plan based off of that pyramid I just showed you to reverse those causes of bone loss. And when I talk about reversing osteoporosis, that's what I actually mean, is reversing the causes of osteoporosis. And then the impact on the imaging scores will just be the icing on the cake later on down the road. The third R is a really important one. And this is where you guys as providers can come in to retest and make sure that you're headed in the right direction. I hate hearing stories where somebody goes on a great plan they assume that it's working, but they don't actually retest to make sure that it's working. And then they either suffer a fracture or they wait 2 years, they get another DEXA and their DEXA looks worse. So we have to retest. We have to retest early. And then the fourth R is my favorite: revive your life so that you can live without the fear of fracture. And that's all I have for you today. I hope that was helpful. Thank you so much for having me.
Thank you so much, Dr. Doug Lucas, for that insightful webinar. And thank you to everyone watching for joining us today. We hope you learned something useful. Watch your inboxes tomorrow for a link to the recording and to access the resources we shared today. You can learn more about the research behind the Dutch test at dutchtest.com/research. And make sure to visit the Become a Provider tab at dutchtest.com to register for an account so that you can gain access to even more hormone education and research. Be sure to follow at Dutch Test and subscribe wherever you get your socials to stay in the loop for upcoming webinars and podcasts.